इन लाईव्ह स्ट्रीम. ओके,
व्हायला लागलं का?
लाईव्ह चालू झालं सर, बंद करा
मेसेज आला लाईव्ह स्ट्रीम. पण लिंक कुठे आहे युट्यूबला बघायची?
थांब की जरा.
थांब जरा, बोल नको ऋषिकेश.
एमक्यूचं पेज उघडेल सांगितलं होतं त्यांना. एकच मिनिट. मी दिसतोय ना रे? मी रूम मध्ये आलोय वरती. ते केलं लॉग इन मी. आता फक्त ते लाईव्ह स्ट्रीम मी आता हे कस्टम लाईव्ह स्ट्रीम झालं, पण ते वेगळंच काहीतरी दिसतंय. आता ते मागच्या वेळी युट्यूब वरती कसं गेलं होतं?
बाद में खाओगे खाना? हाँ, बाद में ही है. Mutton with rice ki chicken with paratha?
Computer, it will get solved if you use these earphones. My
No,
computer
there is
also has, laptop also
some
has
other
same
problem. It is not a problem of this earphones. The voice is just breaking. I will show somebody tomorrow. There's no issue.
I change it for.
So, Dr. Kalra, we will begin. I think it is 8:05. We should start on time.
Yeah, good. That's the tradition
good.
of CSI Pune.
Yeah. So, welcome, dear friends. I welcome you all to this month's clinical meeting. As we are all aware that cardiac imaging nowadays is playing a major role during coronary interventions, especially OCT is helpful in proper characterization of the atherosclerotic plaque. It can tell us about circumferential calcium, can guide us about proper lesion preparation, either with rotablator or IVL in case of calcified lesions, can differentiate plaque erosion from plaque rupture, and can guide us as to who needs stenting, who does not. And it is important during bifurcation stenting and in post-stent optimization. To take us through this very important topic, we have an expert in the field today in Dr. Selvamani, who has a vast experience in OCT. He's going to speak to us about OCT in real-world practice. He is Senior Interventional Cardiologist at the Meenakshi Mission Hospital and Research Center, Madurai. And on behalf of CSI, I extend a warm welcome to Dr. Selvamani. The moderator for today's meeting is Dr. Kalra. As we all know, he is the professor and head of department of the Bharati Hospital, Pune. I now hand over to Dr. Kalra and I request him to kindly call Dr. Selvamani for his talk.
Thank you, Dr. Rajiv Sethi. It's a pleasure and honor to sit here and listen to a luminary like Dr. Selvamani, who has vast experience in interventions. I believe 20,000 PCIs or more, which is remarkable. And he has been using almost every technology known to us today. And we look forward, Dr. Selvamani, we look forward to your talk with great eagerness. I'm sure all my colleagues who are logged in will appreciate learning something about this. It's not new, but it's rather expensive technology, which not everyone has been using of late. So without wasting any more time, without holding viewers from you, I will request you, Dr. Selvamani, to start your talk on OCT in the real world.
Oh, I think there is another screen there. Hold on. Sorry, I think something went wrong. Can you see my screen now?
Yes, OCT in clinical use. We can see.
Yes.
Yes. Sorry for that small hitch there. Thank you very much for calling me to be with you. And it's always a pleasure being with people in Pune. I have visited your place a few times.
Yeah,
and
Ruby
I think
Castle.
I have physically also I have given a talk in your CSI meeting, probably some 3-4 years back.
Yes.
And nice to be with you here. And with this today, what I have done is we will see OCT in different subsets. And instead of talking on general OCT, which you people are already very much familiar, we will just talk on different subsets of ACS or by calcification or bifurcation. And then we will see what is the utility of this OCT. What we will do is after two parts, like probably after an ACS on bifurcation, we can have a discussion and go to the next session also. And I have been requested to talk at least for around 45 minutes to 1 hour. I think you'll have to bear with me for such time, and you can stop me anytime for the interaction. So coming to this acute coronary syndrome, many times we are not very keen in doing OCT or imaging during acute coronary syndrome. Reasons being, probably it's an emergency or it's not available and so many issues there. But when you look at the guidelines, it's very, very obvious. Many times intracoronary imaging is very, very useful during acute coronary syndrome. If there is a clear-cut lesion, there is no problem. You can go and do the plasty there. But many times we will have a confusion, like which is the culprit lesion or the angio is ambiguous. Then definitely imaging tells us what is the reason for his acute coronary syndrome, and you can decide on the therapy also. So this is for a basic small example, an inferior wall MI thrombolyzed patient who comes for an angioplasty stenting. And this is the lesion there. Anybody would have just put a stent there and dilated. It's a very simple, straightforward procedure. So when you do an OCT in such a lesion, what do you get? And see, it's a very clear image there. By angiogram, what we would have done is we would have done a direct stenting there. Probably 5 minutes, the procedure is over. But here, when you do an OCT there, the OCT is clearly showing an area of ruptured plaque there. This is the ruptured plaque, what you are seeing. And the lumen area is here. And you can definitely, angio-wise itself, it's a 70% lesion there. And on OCT also, it's a clear ruptured plaque with narrowed lumen. And you know the EL size here, size of the vessel. And you can make out the length of the lesion also. And then you go ahead and stent it. So apart from that, you get the characteristics also, cholesterol, macrophages, microvessels, and many times thin cap fibroatheroma. If it is very near the lesion, you can cover it with a stent there. So angioplasty stenting done, very clear. And post-procedure, you can clearly make out that there is no dissection. And you can see what work you have done and what is the minimal stented area that you are getting and what is the maximum expansion that you can get. So these are some of the advantages. Apart from that, you look here, this is the case, again, an inferior wall MI who comes to the hospital, and angiogram is like this. So many times we are not very sure what to do for this case here. If there's a thrombus, is there a lesion or not? When you do an imaging in such a case, like when you are not sure what to do, it gives you a clear idea. See here, what has happened is it's possibly a rupture there, and there are some thrombus, and this is the lesion, and this is the lumen area here. And if you get a lesion like this, you can be very sure that probably since the lumen area is very good, and although there is a small rupture, the advantage of stenting is controversial. But at that time when we did this OCT angio, probably this around 4 or 5 years back, all the ruptures we were stenting at the time. So we have stented that case there, and then with a very good results. And in a case like this, where after thrombolysis, you don't see any lesion. For example, it is something like here. This is the anterior wall MI thrombolyzed patient. So what you are doing is you do an imaging there, and then you just look for the lumen area, you look for the plaque characteristics, and you look for ruptured plaque there. But here in this case, there is nothing like a ruptured plaque. The lumen area is very good. And there are some irregular surfaces. Possible it's an erosion and a thrombus there. So if you get a lesion like this, we all know that you need not treat this patient at all. We can just put them on medical management instead of putting them on a stent there. So this patient was left on just medical management. And but this is the characteristics of the OCT that we are seeing here. And such patients do very well with medical management. And in a patient with an acute MI like this, who comes there, you do a thrombosection. And after thrombosection, you get an angio like this, where it's a very diffuse disease. And you really don't know how long the stent you should put and where is the landing zone. And in such a case, if you do an imaging, it clearly tells you where to land, what is the pathology, and what type of stent. Everything is very clearly described by OCT here. So this patient, he had, after thrombosection, you can make out the rupture here, and you know where there is a normal area. When you get this trilayered vessel wall, where you can see the intima, the media, as well as the adventitia. So probably that area is a relatively a normal area, or it's a fibrous lesion there. But this patient has a diffuse disease. You look at this, there is a plaque even there, even at this point, and then everywhere it is diseased. So in such a case, how do you decide on angiographically? Also, it is difficult to decide, or empirically you go ahead and do it. So we here, what you take is, you should take a landing zone area where the plaque burden is at least less than 50%. There should not be any lipid plaque, not much of lipid plaque. If it's a fibrous plaque like this with a 50% or less than that, you can look at that area as a landing zone. So that is what I have selected here. And it's somewhere around less than 50%. We are not getting a better area than this. So probably this is the best area where you can land it. So I have landed it and done the stenting there. And post stenting, you see that there is no dissection, and it's an excellent stent expansion that you are getting there. And we can avoid multiple shots of angiogram also to look at whether there is any issues there. Instead of that, you just do a OCT, you clearly gives what is the stent expansion, and you can find a clear landing zone. And many times in an acute coronary syndrome, you get a lesion like this. There is something hazy or some intraluminal filling defect here. So in such case, what you do is, you do an OCT, you can clearly pick up, this is a clear recanalized thrombus. So multiple channels, and you get a lumen like this. And in an acute coronary syndrome, this is probably a recanalized thrombus, which is giving that appearance. Many times, so this is also a similar case where the angiogram is looking like this. Have a look at this angiogram. Most of us, we think probably it's a thrombus or it's a spontaneous coronary artery dissection for some reason. So to be very definite, you can do this OCT. It gives clearly like this. And not only that, whether you should stent this area or not, that is also a very important point. Many times where I have done a FFR in such lesions, it is usually positive. So angiographically, it's very difficult to take a decision. OCT wise, how you can do is, you can calculate the effective lumen areas of all the lumens what you have, and you can decide on the lumen area, and then you can take a decision for stenting. But usually it is probably all the FFR in such cases are positive in most of the recanalized thrombus. So here, look at this. The angiogram also looks similar to what we saw previously. Some intraluminal filling defects, and again a doubt whether it is a SCAD or whatever it is, it a recanalized thrombus. On OCT, it is a very clear image there. There is no recanalization of the thrombus. But when you just see there is an intimal break and there is an extension into the media there. So probably this is a spontaneous coronary artery dissection. Here the lumen was normal, so the patient was left on medical management. We are all familiar with the need of imaging, and today the guideline also says intravascular imaging facilitates the underlying plaque etiology, and it will help you in tailoring the therapy. And of course, OCT is a gold standard to detect thrombus dissection, apart from all our routine dissections and as well as thrombus and all other reasons. So common causes of acute coronary syndrome: calcific nodule, very difficult, you can't make out in an angiogram; erosion, rupture, spontaneous coronary artery dissection, and fissures. All these things can be clearly made out on OCT, and you can decide your therapy on the findings also. Many times erosion can be just left on medical management. We know this erosion study, which they have clearly said that if there is no rupture, we can put them on medical management. And this is the same slide which I already showed you. And whenever you do an OCT in acute coronary syndrome, if there is a ruptured plaque and lumen is narrow, or if it's a calcified nodule, you should do stenting. If it's an intact fibrous cap without any rupture there, probably erosion, you can defer and put them on medical management. And recanalized thrombus and spontaneous coronary artery dissection, all these things, you can decide on the case by case whether to stent it or not. Many times, all of my friends ask, will you do OCT in all cases of acute coronary syndrome? Yes. See, only problem is if there is hemodynamically unstable patient with pulmonary edema and shock, you cannot give a contrast load there. In such cases, we cannot do. If it's a huge thrombus burden and TIMI flow is less, again, we won't get a good clearance for OCT, so we may not do that. And if there is a no reflow due to distal embolization, again, in such cases, generally we don't do OCT. And if there is renal failure, nowadays we can consider extension catheter and saline instead of contrast. So these are some of the conditions where we generally do not do OCT. In most of the cases, otherwise, we tend to do OCT in all acute coronary syndromes. So now, I think somebody's mic is on.
Can we request everyone to mute themselves? Everyone can please mute themselves.
Okay. So now, okay, fine. And next we'll go to the bifurcation techniques in OCT. See, actually, in bifurcation, OCT has so much of advantage, which no other imaging modalities can tell us these things here. Apart from stent landing, which is a routine thing, we can just look at, decide whether you can land at the ostium or need to cross over to do a real bifurcation. Whether single or double stent, you can have the predictors of side branch closure, and then crushing balloon sizing in DK crush. And you can look at the metal deformed carina, and you can look at the optimal side branch cell crossing. And of course, kissing balloon and pot balloon sizing, everything is very, very easy with this. Look at this case, whether to do and how to do this. This patient, he had presented to us with an acute coronary syndrome. Angiogram was done elsewhere, and this patient was referred for bypass surgery in our hospital. So he has a proximal LAD disease here, and there is a disease in the mid LAD here, and there is a moderate to large size diagonal, which is again 90% stenosis there. So when you look at the LAD lesions angiographically, proximally, it looks it's calcified, probably it is disease there. Now the question was, should we do a bypass surgery or do something else for this patient? Or if you are doing angioplasty, where to do? Should we stent from the proximal LAD to the mid LAD, or do what? So what we did is, I did a FFR in the LAD, which was negative. And you do a OCT there in the LAD also. So you get a clear lumen area. So lumen is not so narrow here in the LAD. FFR is negative and OCT lumen area is good. Look at the proximal LAD here when the marker comes here. Lumen is reasonably good. It is more than 4.5 to 5 there. So this patient where you was referred for bypass, he does not require anything to LAD. So only thing was a diagonal which was left there. So generally in such a diagonal, which is ostium also is disease, what we generally do is we try to do a crossover to cover it. But should we really do a crossover or just land at the ostium so that you are not touching the LAD at all? When you do a OCT, you see here, you clearly see that this is the ostium of the diagonal. So this is the OCT run from the diagonal here. And you get the lumen area and look at this. This is the LAD diagonal bifurcation. Clearly the carina, there is a gap there, and you can really do stenting to the ostium of the diagonal rather than do a crossover. So to do that, we use a technique called as boom technique. What I use is generally this the red mark. This is what is indicator of the ostium of the diagonal there. And that is what is this point, which is indicated there. So you keep your stent looking at the angio co-registration exactly there. So if you go by angio, probably many times we try to pull the stent back where we are not sure about the ostium. But here we have clearly marked where the ostium is. So just keep the stent there exactly, and then you deploy it. So this is post stenting there here. And many times we have a doubt whether have we covered the ostium or have we extended beyond the ostium into the main vessel. So post procedure, look at this OCT. This is the diagonal ostium. It's a precise landing at the ostium of the diagonal here with this exact spot, that blue spot here. And this is the longitudinal here, longitudinal view. And this is the LAD bifurcation, LAD here going, and this is the diagonal. So exact placement there. So this is, and you do a run in the from the LAD also, you don't see any metal there. So you have covered the ostium of the diagonal exactly there by angio co-registration and just pinpointing the ostium and placing it there with the boom technique. So boom technique is a bifurcation ostial OCT mapping. So what you do is you look at the ostium on OCT, and in this study, which was presented in this 2CT 2018 itself, and they enrolled this patient, number of patients, and what they projected is almost 70% of the time you can land within 1 millimeter of whatever you have decided, and about 90% of the time within 2 millimeters, and within 3 meters to millimeter is around 90% of the patient when you use this technique. And many times it is useful in precise placement, minimizing overlap for metals there. And it's a very useful technique when you have this angio co-registration. And coming to this patient here who has an ostial lesion, in this patient, should you do landing exactly there in the ostium or do a crossover? So basically, when you do an OCT in such a case there, you just follow this here. So if there is a plaque, so this is the left main circumflex disease there. Ostium is tight, and you look at the plaque characteristics. If the plaque is extending into the left main, and you look for any other issues here, when you look at this OCT run here, there is a dissection. See, there is a dissection there at the ostium of the LAD there. So clear ostial dissection and the plaque extending into the left main. So in such case, you shouldn't do a precise landing. Probably you should do a crossover. And that is what we have done here, done a crossover and then stented there. And coming to another interesting point in OCT is how to decide whether the side branch is going to close or not. So we have certain predictors which you have, we can look into that OCT images. So what you generally look is, in the longitudinal view, this is what we call it as carinal angle. If this angle is more than 60, then chances of occlusion is less. And then you will have to look at the distance. This is the branching point and the carinal point. If this distance is more than 1.7, then chances of closure is less. And then you look at the characteristics of the plaque opposite to the carina. If there is a lot of calcium, then probably it can close. And look at around the carina. If there are a lot of lipids around the carina, then again it can close. And plus, if you oversize your balloon to the distal main vessel, again the branch can close. So these are some of the predictors. Look at this case here. This patient has a moderate to large size diagonal. And this is the OCT longitudinal view here. These are the points that we are looking at. And here, this patient you see here, actually there are two diagonals. One is here and one is here. And probably we thought this was the main diagonal, and then we thought the distance is bigger. So we thought it may not close. That is what is many times it happens. So you'll have to be very careful, which is the diagonal. And there is a pointing carina, which we call it as eyebrow sign in both IVUS as well as OCT. If it is like this, then the chances of closure is very, very high. So this patient, what happened after stenting you see here? So once this patient was stented, the side branch closed there, the diagonal closed this. So why it closed? Basically, what it had is, there was an eyebrow sign here. There was significant calcium opposite to the carina, and this distance was very less. That is why once stented, the side branch closed. So these are some of the important side branch closure predictors. And coming to other important points like crushing balloon size in a DK crush, it's a very important point where you should do a crushing. So this patient, we have stented the circumflex and we have used a 4NC to do a crushing. And after recrossing, generally when you do a OCT, if you see something like this in the main vessel, if it's an adequate crush, generally OCT does not pick up this metal there. If it is something like this in the stent rendering, that indicates probably the crushing is not adequate. So what I have done is, I have taken a bigger size NC balloon according to the main vessel size, and I have dilated it. And once dilated, this is what you see, a very few struts, minimal struts there, and it is not picked up on stent rendering. So probably this is an adequate crush. So selecting that size is very, very easy. And coming to a kissing balloon size also, you need not remember the Fillet's law or Millet's law for knowing the main vessel, mother vessel, branching vessels and all. You just measure the both side branches, and you take the balloon size according to the distal vessel of the branches and you dilate. The main vessel will hold it, and then you will have an easy kissing. You need not worry much about all the formulas and need not guess so many things. Just measure according to the side branch vessel distal measurement, and then you go ahead and do a kissing. It is so easy to do with this. And coming to ideal cell cross, it's a very, very important point. And most of us today, we do left main bifurcation. And we know that Achilles heels of left main bifurcation is the circumflex ostium. Why you get ostial restenosis is when you do stenting there, if there is a lot of metal bridging there and a lot of metal crowding there or struts accumulation, you tend to get high restenosis in this area. So to avoid that metal crossing, what should we do there? We have a lot of insights into what reduces that metal bridging. And at the same time, if there is a link across the side branch like this, what happens to that is also an important point. So when there is when there is a link like this is the ostium. Over a period of time, it gets endothelized and there will be narrowing of the ostium. So this is a big problem when there are struts across the side branch. So, and again, when you stent a patient across the side branch, you can get this type of combinations of struts across the side branch. There can be a carina, or there can be a connecting type of carina where there are links across the side branch. And in all these things, you might have a distal and the proximal cell. In most of the cases, when you're trying to recross, it is better to cross distally, except in DK crush, where we try to cross as non-distal cross, proximal or mid-cross is very useful. So why you say that is, so there are certain points also, and there is a paper published by Okamura. What they said is, whatever the reasons why they get suboptimal cases, and they looked into analyze the causes, they found that link connecting type 1, when it occurs, if the guide wire is not crossing distally, angle between the side branch and the distal main vessel, that is the angle, and proximal main vessel reference. So these are some of the predictors where you get this abnormal results. And when you do a distal crossing, what happens is here, the stent is there, even in a provisional stenting. If you want to do a final case, if you cross distally and you dilate, do a case, you cover the ostium of the side branch. And this is what happens. If you do a proximal cross and you do a kiss, you are going to distort the stent, and then the ostium is also not covered there. So that's the reason we always recommend distal crossing in most of the cases. So how to make out this crossing? This is also very important. When you look at the longitudinal view here, you can see that the wire is crossing in the distal cell. And you can always look into that, move it and see that in which cell the wire is crossing. So this is the distal cross there, very clear cut. And you can do a 3D reconstruction also. And you can see in which cell it has crossed. And this is a 3D reconstruction and make out, even in a distal cell, if it's a very remote cell like this, probably it is not an ideal cross. You should cross with this cell. If possible, you can recross. Otherwise, probably go ahead with that. And in a single stent, most of the time, this is what is we practice today. Double stent strategy probably is not so common. Our most preferred option is single stent stenting in most of the settings. In that, should we do a final kiss or not is always a question. And how you decide on that is also very scientific here. And many times what happens when you stent across the main vessel, that is from LAD into the left main, and if you get a struts like this across the circumflex. So if you get a strut like this, that means it is not ideal. And if there are struts like this across the circumflex, then again it is very, very bad because there are so many connectors, and then there is a chance that it will get endothelized and you can have that reduction in the lumen there in future. So what I do is, in such cases, I try to do a distal cross here. And in an anatomy like this, many times you can make out whether it's a distal or a proximal cross on an angiogram itself. But unfortunately, if the anatomy is like this, it's very difficult to make out in which cell we are crossing. So the OCT clearly shows that in which cell we are crossing. It is a distal cell here. Then you go ahead and this distal cross there, and you go ahead, and again you can look at the bifurcation mode also, how you are crossing it. And you can, this is the run through mode, which we make use to see the connectors as well as the strut in which we are crossing. And final kissing, you see here, this is what you should aim there. There should not be any metal across the side branch, and there should be a clear figure of 8. Similarly, even for pot, side pot, see, there are struts across the side branch. And after you do that pot and side pot, you will not have any struts across the side branch. So these struts which were across was removed by that. So this is also an important point there. Why we say this is a small example which I am telling you. This is an follow-up OCT 1 year. And this was done in 2018 and 1 year follow-up. Initially, there were struts left across like this. 1 year later, what happens is that struts gets endothelized. When there is endothelization, it looks like this on the angiogram. It looks like something like a thrombus. And this is what is happening there to the struts there. Naturally, it will reduce the lumen size. But this is not so important in diagonal. But in left main circumflex, it's definitely important. Many times, when you do an adequate pot, this struts will not be there, it will go off. But in spite of that pot, if you see any struts like this across your side branch, probably then at that time you should do a final kiss. That is how I practice. But anyhow, this point is always controversial. You can always discuss in any way. So now look at this bifurcation point. Look at this angiogram. It is very clear. But when you see this OCT, there are so many points here. See, there are struts across the side branch, and there are certain areas of malapposition. And then these things you cannot make out in an angiogram. Angiogram looks the same. And this is in a crush, probably this is, I have done a culotte, and before kissing, this is how the angiogram looks. And OCT looks like this. And this is after kissing. The angio is the same, but look at the OCT. There are no struts across, clear figure of 8. And this is what we should aim in a patient with bifurcation when you are doing two-stent strategy. This is an example of DK crush there. The ostial LAD and diagonal. I will just skip this, go fast here. Generally, we try to get a proximal cross here, and that is non-distal cross in DK crush. And we do a kiss there and keep the main stent there. And after doing a pot there, you again, after rewiring, we do a stenting of the main vessel and do a kissing there. And at this time also, we try to get a mid cross or probably a near distal cross finally, and then go ahead and do a kissing there. And this is the final results. And in the results, the main aim, what you should aim is, there should not be any struts across the side branch, and you should be well opposed. A clear figure of 8 image like this is an ideal result for two-stent strategy there. So again, to re-emphasize, in bifurcation stenting, OCT has so much of advantage. And I have already told you all these things. And if there are any doubts, we can always discuss. And of course, I have calcium as well as ISR and some interesting cases. Shall we have some discussion now, or shall we go to the finish of all the lesions and then have final discussion? It's left to you. Whatever you suggest, we can do like this.
I think you finish.
Fine, sir.
Finish your presentation. I'm sure those who are keen to know about something, they would have noted down.
Fine.
What do you say, Rahul?
Right, sir.
Yes, sir, well said, sir. Well said. Because, yeah, those who are keen to know, they will note it down. Yes, that's right. Yes.
In fact, I've been making notes, so I'm sure others also.
Yeah,
sir, now coming to another important aspect is calcified lesions, which is really a problem nowadays, because most of the time we are treating all elderly patients, patients with so much of complications, renal failure. Then the chance of calcification is very high there. And it's for a basic thing here. So how do you make out a calcium is? So this is the vessel wall there. And you look at this is a low attenuation area. One other thing is, if you can make out the entire low attenuated area, and you can see the behind of that, this is how a calcium looks in an OCT. The same calcium on an IVUS looks like this. There is an high intensity signal there, and beyond that you cannot see anything. But here there is a low intensity, well demarcated area which represents calcium on an OCT. And this is the concentric calcium on IVUS. It's picked up very clearly, hyper intense area. And here the same concentric calcium on OCT, which is seen here like this. And look at this calcium. It's a thin plate of calcium. And look at this IVUS. This is a thin calcium. This is a thick calcium, and this is a thick calcium. But here in IVUS, both the looks the same. But in OCT, you can really make out the thickness of the calcium, what thickness this calcium is. So this might help you in deciding your therapy also, like probably you want to take a bigger balloon or you want to take a IVL. All those decision making can be useful, measuring the thickness of OCT. But of course, the arc, the length, and then depth, the deep is the very important aspects of calcium, which you make out on OCT. And this is the calcific nodule. which is a real problematic issue in treating calcified lesions. This is the reason why many times you may not be able to track your devices. It will give you an appearance like this on OCT. And this is an clear calcific nodule, which we had a lot of problems in treating such lesions today. And this nodule can be confused with a thrombus, but how you differentiate is this nodule usually is present in the calcified plate. When there is a lot of calcium in one area, there is a projection like this. And red thrombus is usually, if you pass a balloon, it will disappear there. And many times it can be confusing, like a nodule there in an acute coronary syndrome. And calcium, basically, there are three types: deep, nodular, and superficial. And you know the mode of therapy. If you cannot track anything, probably you'll have to do an rotablation, probably you'll have to do a laser. But if the wire crosses, but if the balloon does not cross, then probably you'll have to do a rotablation. And after doing a rotablation, when you take a balloon, then you do imaging and then decide whether it is probably you want to go ahead with IBL or do something. It's a very, very useful thing, which I will tell you. And for calcific nodule, it is always controversial. If there is a good wire bias, which we can make out on an OCT, you can use rotablation and then you have a good results in such cases. And calcium scoring is a part of OCT, where you look at the maximum calcium angle, calcium thickness, and calcium length. And you have these points there. And if the point is more towards 4, then the chances probably you will have to use extra devices to get better results and to get excellent stent expansion. Probably you should be ready to use other devices apart from routine NC balloon. Probably you'll have to use a cutting balloon or a scoring balloon or an IBL or a rotablation. So those things might be dependent, will be required depending on case by case when the scoring increases, like when the score is more. And main aim in calcification is this. Basically, there should not be any complication, and you should get a minimal stent area, which is at least more than 80% or at least above that. In Illumine 4, we are aiming at 90% of stent area there when referred to the compared to the reference area. And to achieve these results, what we should do is the imaging is very, very helpful in calcified lesion, because only angiogram, the prediction is less, and then your outcomes are not predictable. But the sensitivity of intravascular imaging is very high, and definitely not only diagnosing, it helps you in your treatment also. So look at this case here. We had a lesion like this, presented with significant class 3 angina, unstable angina. Angiogram looks like this. And when you do an OCT here, what happens is there is a projection here. So at this point, there is a projection like this, which is happening, and it's a calcified lesion. So what we did is we tried to balloon that area, and then after ballooning, so we did not really concentrate much on that area, and the patient was stented. And after stenting, see what is happening here is, and was dilated with so much of balloons also. This is the stent, and this is the area where there is calcium. And clearly you see here, this calcium nodule is not allowing the stent to oppose here. And it is very tough there. Whatever size OP, even OP and NC also did not expand this nodule at this point. One point you should be very careful is when you are chasing something like this, when you look at the opposite of this, if there is no calcium, if it's a normal vessel wall, be careful, don't try to chase. If the lumen area is adequate, I think you can accept it and come out. Otherwise, you tend to have perforations opposite to this. So that is a very important point you should remember. So he accepted it and came off. And angiographically, you see here, you just can't make out anything. Everything looks the same. whether there is malapposition or nodule, well exposed expansion, you really can't make out in an angiogram. This is another similar case there. So we couldn't pass any balloons there. So very tight calcific disease in the left main. So started off with a rotablation there. So did a rota. And when you do an OCT in such case, one important point, see here, this is the rota catheter or the wire. So if this is near the nodule like this, we call it as it's a good wire bias. That means in such a case, if you use a rota, this rota will ablate this nodule. So when there is a good wire bias like this, you can use rotablation in calcific nodule where you will get an excellent result. So this was done. You see this is the nodule being ablated by this rotablation. So stented there with excellent result there. And you see the stent is well expanded in this case there without any malapposition or under expansion. And coming to any classical case of calcium, how we treat is, so it's the step-by-step which is very useful for any routine calcium. When you do a calcified lesion, you do a OCT, it is like this. So you get a basic idea. So this is the circumferential calcium. What is the distant reference? What's the proximal reference? What is the EL? And what is the thickness of the calcium? And what is the length of the calcium? So length you see here in the longitudinal view. And once you see that, you can make a decision. But here in this case, what we did is after this 2 balloon, I couldn't track any balloon there because it was some nodule or something. So I used a rotablation in this case. And once after rotablation, when you do an OCT there, so these are areas, you see are clean shaven areas. These are ablated areas. This fracture is due to balloon dilatation. So this ablation is usually very clean like this. And there was a dog boning in spite of rotablation there. So what I had to do is we had to use a bigger cutting balloon, an OPN balloon. And when OPN balloon with 35 atmospheres yielded this, and you see that there's an excellent fracture produced there. And the lumen area, which was 1, it has come up to 4.14. And on imaging, if you demonstrate good fractures like this and good lumen gain, that is the point where you can decide to take a stent. Without having that adequate lumen gain or good fractures like this, if you put a stent, chances of under expansions are very high. And moreover, if you're not using an imaging, generally what we do is we take 1:1 size balloon and see that the balloon dilates without any waste. So if that happens, you can still take a stent and go there. And this patient was stented. And now our aim is to get at least 80% stent expansion. Although the LAD stent was expanded very well in the distal segment, proximally also it was well expanded, but it was lesser compared to the reference area. So we know that the EL is around 4.5 in this area. So step by step, what I did with a 4 NC balloon. And with 4 NC balloon, we got an MSA of 5.7. And since I was very sure about the EL, I took a 4.5 NC balloon in this proximal LAD and got an area of 7 there. So imaging not only helps you in diagnosing calcium, it helps you in guiding the therapy. You can decide your balloon size confidently and go ahead. And this is the final result without any maximum complications there. And one interesting case of calcium, which I did recently is, this patient, you look at this angiogram, anybody will think this looks like a thrombus there. And he was treated elsewhere, treated by my friend somewhere in some other hospital. They treated with heparin and then they took him for angioplasty. When they took him for angioplasty, wire went, but they couldn't take the balloon there. With great difficulty, they took a balloon, but it could not dilate there. So basically, it is something, it's a thick calcium there, which is looking like a thrombus, which anybody can get confused. It's an intraluminal filling defect, just looking like a thrombus. So here he was referred to me for this. And what I did is I couldn't put any balloon inside there. So I straight away I started with a rotablation. Since we couldn't track any balloon and couldn't take any other devices, only option left was to do a rota. And I have done a rotablation there. And after rota, angio looks like this. And you do an OCT after this rotablation. Look at this point. This is the calcium here in the angio co-registration. And you concentrate on this area. It's all a circumferential calcium here, severe calcium. And these areas, see, there was areas of calcific nodule. Look at the stills here. This is the calcific nodule which has been projecting, and it's a good wire bias. So rotablation has shaven off this calcific nodule here, and these are the shaven areas of the calcific nodule, and you get a good lumen. Now after this, I could track a balloon, and since it was very thick calcium and very difficult to get a good expansion without that, and we used IVL there, intravascular lithotripsy, and we just dilated at that vessel. And after NC, after IVL also, this is the OCT pullback that you are seeing here. There is a good luminal gain there, and there are areas of significant fractures that you can make out. There are fracture, and then probably now this is the point where we can take a stent confidently and deploy there. And it was deployed with good expansion and excellent results there. No under expansion, excellent stent expansion with good result without any complication in a severely calcified lesion, which was I attempted outside and could not be done without this rota and IVL there. And this is the final thing. And I think under calcium, imaging is another important use. How I use this OCT is in a vessel like this, which is severely calcified from here to here. When you treat, you always land up in trouble. Like you may not know where you will have under expansions. So in such case, what I do is I do an OCT, and then I do the markings here on angio co-registration. We can mark the thickness of the calcium. And see, this is, you follow this white marker. This is angio co-registration. This is the cross-section of that area. So at this area, this is the cross-section. And when you come up, I know that at this point, what is the thickness of calcium? And then I just come up in different areas. See here, at this point, there is a calcific nodule. So I am very sure what is where in this, and I decide my therapy on that based on this OCT imaging. I can put a mark there. So in this patient, what I did is, when I used the IVL, I gave extra shocks there at the point of nodule. And then, but where there was thick calcium, I just give the extra nodules. And then was NC balloon, and then you take an OCT there, you look at the lumen, and you can look at the calcium again. If there is any doubt, you can go with the second attempt at the nodule as well as areas where you feel that the calcium has not broken properly. And then you go ahead and put a stent there. So this is a stent after using this imaging with excellent expansion, and there is no under expansion at all, and there is no complications. So these are the advantage of using OCT in a calcified lesion. And you can look at the area where there was nodule. So here, the area, it was nodule here. Although we have not got symmetrical expansion, there is asymmetrical stent expansion. Lumen area is adequate. So probably we can accept this results in this calcific nodule zone there. And the important point you should remember is the complication. So perforation is one of the commonest important problems with calcium. And see, this patient had a perforation, and then it is sealed here. So on imaging, how do you think this will look on? So I did an IVUS in this patient. So what I can see here is, so there is a bright shadow here, and this is the calcium, and this is opposite to the calcium. Usually perforation is like that. If there's a calcium eccentrically in one area, Opposite to that, generally you get perforation if you try to over dilate those areas. So here, when I have dilated, so this is the perforation that is seen on IVUS. Same patient I have done a OCT. So this is how the perforation looks here. So this is the stented area. It is looking like this. This is coming like this. What has happened is, see here, there was a flap-like thing. Because of prolonged balloon dilatation, this flap got closed here. And that is why this perforation got sealed. And when you compare these two images, see there is a calcium here on OCT, and opposite to that is the perforation spot. In the IVUS, there is a calcium here, and opposite to that is the perforation spot. So basically, this is how it looks on imaging. This is not done usually, because this patient, I had an opportunity to do it, I did it. And one more than that, very important point is, when you are treating a patient like this, so this patient, I dilated, and then I did the imaging. So in this imaging, actually, if you concentrate, what has happened is when you dilate, there is a break in the intima media and it is extending into the adventitia. If something like this is extending, then probably you should be very careful in such cases. If you try to over dilate, you can have perforations there. So what happened? So this patient, we went ahead and dilated, but finally, after the dilatation, he had significant pericardial effusion, perforation, and we had to do a tapping there. So one of the important predictors of perforation is when you do a pre-OCT, this point where many times we tend to look at it nowadays, if there is an extension like this into the adventitia, try to be slow in that. Don't try to aggressively dilate those areas to avoid perforations. And in calcium, the worst enemy is if you are not pre-treating the calcium properly, under expansion, once you put a stent and you try to expand, it will not expand. It's very, very difficult. Under expansion is a major problem in calcium. So use imaging, prepare well, look at the lumen gain, and then you put a stent. Then problems of restenosis or stent thrombosis can be very clearly avoided in a patient with a calcified lesion. So I think with this, I think we can go for discussion. I'll show you some one or two interesting cases. ISR is an important point where it gives a tremendous information on the reasons of stent thrombosis, as well as probably for your ISR reason, instant restenosis. And I'll show you one case, probably one or two cases. I have a lot of cases of ISR, but we'll discuss one or two. See, this patient had an angioplasty. 10 hours after the angioplasty, he developed stent thrombosis. So this, what is the reason for this stent thrombosis is always controversial. So when you do an OCT in such a case, it clearly tells you what is the reason. There is a major malapposition left at the proximal of the stent there. So such cases can have stent thrombosis. Although malapposition is not a very bad thing compared to under expansion, but in an acute event, if it's such a malapposed stent, can produce stent thrombosis. So this patient was just treated with, again, balloon post dilatation with excellent result there. And very important, interesting cases. So this patient, he had angioplasty stenting. 12 hours later, he had stent thrombosis. He was treated by my friend, and he was a VIP. And when he looked at the check angiogram, it was looking like this: a stent thrombosis, and then just to put a balloon there, and then he did an angiogram. Everything was looking perfect. And angiogram, he couldn't make out anything. So he had a doubt. He had this was a VIP. So he sent this patient to me for imaging. When we did a OCT in that case, say, look at this angiogram. Angiogram looks perfectly normal, but he has had a stent thrombosis 12 hours after, for which one just balloon was tracked here. After that, he got this flow here. So OCT clearly shows, what it is showing is there is a major dissection here. There is a dissection here. such a big dissection at this part beyond the stent there are areas of malapposition and the area of under-expansion. So almost all the reasons, there is stent, there is a dissection, malapposition, there is under-expansion, everything in this one case, which was the reason for stent thrombosis. So when OCT clearly tells you the reason why he had this problem. So this patient was clearly stented with another stent distally and then post-dilated according to the EL diameter with excellent results, doing very well. And ISR also is a very important problem. What are the reasons are basically stent edge dissection, block edge dissection, presence of thrombus, under-expansion, strength fractures, non-overlapping segments. So these are some of the reasons for ISR. And you can avoid this ISR if you use imaging and treat your patients with PCI. And coming to treatment of ISR also today, we have, depending on the type of hypertrophy or atherosclerosis or neo-atherosclerosis or just intimal hyperplasia, we can decide whether to use only DES or whether to use DEB or to use a combination. We can always decide on imaging. So this is an homogeneous growth, basically seen in patients with bare metal stent, but you can get in a lot of patients with drug-eluting stents also. So such patients, such homogeneous ingrowth can be treated only with the drug-eluting balloon. So these are all calcium-rich neo-atherosclerosis and layered. I'll show you a few of my cases here. So this case had an ISR, and this is the ingrowth there, which is very clearly homogeneous. And when you look at this ISR here, and that too only in the middle part of the stent there, clearly homogeneous. So this patient, what I did was, we treated only with a drug-eluting balloon, put a cutting balloon there. After cutting balloon, just put a drug-eluting balloon there and just left it with excellent, good stent expansion and result there. And this is an example of layered ISR in the proximal LAD. Look at this, there are different layers inside the cell. And this is how it looks there. And very important thing of imaging is, when you prepare this lesion before putting a stent, what you should do is try to cut off to the maximum, so that if you take a stent prematurely without getting this lumen gain, you will have a sandwich of this material with in between the old stent and the new stent, and getting a lumen expansion will be very difficult. To see that, you use an adequate preparation, use cutting balloon or scoring balloon, make sure that you are near that old metal. In such cases, you go after making sure of that, you take a new stent and deploy there. And coming to these two important trials, light lab trials have also shown that in ISR, as well as when you use imaging, it does not cost much of time, and the maximum stent expansion and results are very good with when you use OCT for patients with ISR there. And iOptico is our own study where we did it in India and Bangladesh. In our center also, we were one of the centers for this iOptico study. It has shown that almost when you use OCT and angio-core registration, it changes decisions in almost 90% of the lesions. Pre-procedure, 76% of the lesions, there was changes in the decision compared to only looking at the angiogram. But when you use this, there is so much of change, and probably these changes will result in better long-term outcomes also. And these are some of the important trials that we have today. And I think I'll stop here, and we'll go for the discussions. And there are some rare cases also. If you are interested, probably we can see it later.
Thank you, Dr. Silvamani. You have taken us through the spectrum of use of OCT in your day-to-day use. Of course, that is very high-end, but I'm sure many of us aspire to reach that level. Let me see. Are there any questions from the audience? Well, let me ask you some questions if you don't mind.
Sure,
Uh,
sir, sure.
Yeah. See, your light lab and eye optico and all show that OCT really changes your approach in such a vast percentage of cases. Do you think it is time that we move from class 2A to class 1 recommendation and guidelines?
Yeah, you are very correct. Especially my personal feeling is, for example, for instant restenosis or stent failure like stent thrombosis, we should actually give it probably class 1 indication, because which you really cannot make out on just on an angiogram.
Yeah.
And the only thing how this people decide is probably you need some more trials and some more evidence to prove to make it as class 1 indication.
Thank you. You see, now the one big concern with OCT as compared to IVUS is the use of contrast. So in your practice, have you seen that you're using more contrast? Is there a greater incidence of contrast-induced nephropathy? It's a big concern. Besides the cost is the bigger concern, I know. But in many of our patients are quite ill with marginal renal functions. What would you say about
Yes,
that?
sir. See, if there is a risk for nephropathy, we should be always careful. And what we do nowadays is, but we have really in real-time practice, we have not made out any difference that because of OCT somebody has developed nephropathy, because any of for angiogram we would have used. But as you said that there is definitely an increase in use of contrast. That amount will be there. And nowadays we are doing saline OCTs for RCA. And for selected cases, you can do saline in the left system also. If you have an extension catheter like Guidezilla, you can take it inside, try to get a better clearance without contrast. But still that you may not get a better image like in contrast when you use saline, but wherever possible, you can make use of it.
So how exactly do you do the saline this thing? Where is the saline injected?
Yeah, in the same, just like contrast, you can inject saline instead of contrast, inject saline. You take 20 ml of normal saline in the RCA. In the guide you inject, you will get clearance and you pull back the OCT. You can get a good image in the RCA.
Right. Okay. Okay. And what do you suggest for many of the audience today would be beginners with OCT? What do you suggest? Who should interpret the OCT? I mean, do you interpret your own? Of course, you would be interpreting your own OCTs. But for beginners, do you think somebody should be separately trained? Because we are all used to looking at the screen in front, on the fluoro image, on the angio image. So, how do you define this change? How do you suggest?
Sir, but this is a very important thing. And what I feel is, when compared to IVUS, learning curve is less with OCT because images are very clear and then you get a clear idea. And if you do few cases, you see few cases of OCT, you will pick it up very easily compared to IVUS. And anybody can start interpreting OCTs. And but only thing is, unless you should be regularly doing it, otherwise your interpretation levels will come down. And it is not a big thing, sir. You do few cases, you will easily pick up. OCT learning curve is very, very less. You can easily learn.
Okay, that's very encouraging. I'm sure many of us will try to do more OCT.
OCT.
And one question that I would like to ask you is, where would you not do OCT but IVUS? And where would you not do any imaging?
Yeah, there are so many conditions like which I already told you. If the patient is very sick, like in acute MI or a cardiogenic shock, where saving the patient is more than your long-term outcomes. In such cases, if the patient, you cannot do a OCT, definite, in cardiogenic shock, unless you have a mechanical support and the patient is stabilized. Probably what we do is we stent it, once the patient is stable, recovered, Then we call him for imaging and do an imaging later, and then optimize the stents if needed. That is one. And then if there is OCT cannot be done, if there is significant no reflow there, and if the vessel is very small, because OCT catheter needs some amount of vessel to be there to track the catheter. If you cannot, if the very small vessels, you cannot do that. And probably these are certain places where we generally don't do.
I really liked your detailed description of OCT in bifurcations. All of us will be doing at least 1 or 2 bifurcations in a week. It is a day-to-day problem, and amazing how you sort of describe the value of OCT, because the whole वो हिंदी में बोलते हैं नजरिया ही बदल जाता है. The whole point of view changes when you do OCT. It's amazing. Bifurcations and calcium. These are the two problems that everyone is going to face. CTOs, not everyone is going to do.
Correct.
But bifurcations and calcium is a day-to-day problem. And I'm
Yes,
really grateful to you for giving us the value of OCT. In fact, you will all agree with me that it's been a visual and intellectual treat listening to Dr. Selvamani. I would like the audience to come up with any questions, if there are any. You can do they have to put it up on chat, or can they come online?
They can come on live.
Yeah, please, if there are any questions.
Just Dr. a comment from me.
I want to ask you, you have been practicing for so many years, like so many of us, without all these imaging techniques. In your opinion, unbiased opinion, what is the incidence of target vessel revascularization which has changed before and after imaging? Is it really significant to justify in a routine case, or should I use it? Because in this part of the country, because of costing and so many other factors, we are not doing the way you are practicing, honestly. So which patients, except for these complex bifurcations, left mains, calcific, why should we use this? Has it made a real difference in your target vessel in your practice?
Yeah. See, but this is a very common question everybody asks, and even I have also thought of it. My experience says that even in a simple case, if the patient can afford and if the facility is available, I think we should use it, because angiographically what I'll be thinking it as 3 vessel turns out to be 4, and sometimes even 4.5. And sometimes what happens is minimal complications. We think we are not going to have major complication in this, but we'll land up in patients with stent thrombosis, and then we have this. And only after you get this problem, we do an imaging, and then you come to know that. So these issues are always there, but your point is well taken. Is it really cost effective to do in a very simple case where your complication rates or long-term results that does not affect, where for which you should spend in almost more than twice or thrice the cost of a stent? And that is always a questionable point there. But if the patient can afford, and if you really want to do it, I do it even in a simple lesion. But more you do in a simple lesion, only then you can comfortably do in a complex case. You take a OCT many times in calcified lesion, you may not be able to track your OCT catheter. In bifurcations, you may not be able to track your IVUS or OCT there, unless you are very familiar in doing it routinely. That is a big point there. And unless the patient says he cannot afford, then you don't do it. But ideally, if possible, it should be offered.
I've never thought of doing imaging in a primary angioplasty, because you are rushed for time and you want to somehow establish flow. But it was interesting. You've shown us so many cases in a acute setting. How much does it add to the time for revascularization? Any idea?
See, sorry, the only thing is, the problem is once you dilate the vessel, when there is a flow, then you have all the time there. You need not be in a hurry. You do OCT only after you open your vessel, do a thrombosection. Once you establish the flow, then you take your time and do an imaging there. And that doesn't make a big impact, probably for your stenting, but it's only we are worried about the establishment of flow. So that doesn't make a big impact. And you can take your time. You can do IVUS or OCT in ACS. It will give you, actually, it's very, very useful. Angiographically, we try to undersize this. Your stent will be undersized. Vessels are in spasm, and you are not very sure. And your landing zone is very, very difficult. You might take a shorter stent, or you might take a longer stent. All those problems are avoided if you use imaging in ACS.
Actually, I think it's an extremely useful tool for sizing.
Yeah.
And where
Sizing
your
and
landing zones, your length and your diameter. It's amazing. Any imaging, of course, IVUS
including
also.
IVUS.
You don't have OCT, IVUS, but it's changed our perspective, because I would say we can land our stents shorter. We can use shorter stents than. What do you think? Because we tend to use very long stents, trying to cover up a lot of territory.
Yeah, what I have, my experience is in non-STEMIs, when you use imaging, we tend to use probably the longer stents compared to angiogram, because when you look at the ideal zone landing, generally stents becomes longer. But that doesn't mean that that's longer. Actually, that is the ideal for that case, because on imaging we have seen where is the landing zone and what it is, and till what extent that's ideal. But angiographically, you might feel you would have put a shorter stent. But when you use it in acute coronary syndrome, as you rightly said, we always tend to put longer stents there, because we feel that it might get embolized, or we are not sure of the landing zone. There you can give an exact length, a precise sizing can be done.
I think there's a question from Dr. Jnanesh. He wants to know, how do you compare IVUS versus OCT? It's a very broad-based question, I know, but would you like to? Because you are doing both.
Rather, we can say whether OCT has taken over IVUS.
No, nothing. It's all complementary. See, IVUS has been for a long time, and there are certain issues. See, IVUS, to acquire an image is easy, but to interpret the image is difficult. In OCT, acquiring the image is important. You need some technique, you'll have to do it and get a good image. Once you get a OCT image, interpretation is very easy. And you know that resolution of OCT is very high, 10 times higher than the IVUS. So you get better images. And IVUS has better penetration. Like, for example, if the vessel is very big, 4.5, 4 and all, OCT may not show you the entire pathology there. So in such cases, IVUS is useful. And sometimes you may not track a OCT catheter, IVUS will go. Sometimes IVUS catheter doesn't go, but OCT catheter will go. So it's all complementary. It is not this is best and that is best. But off late, with the available technology and the clarity, OCT probably slightly better, but the disadvantage of contrast is always there.
Okay, thank you. Thank you for that answer. Dr. Kannan from Madurai wants to know, has OCT helped you to adjust the heparin dose during a long procedure?
I don't think so, because usually heparin, we look at the ACT and then the duration and then take a decision. But I don't think OCT helps in that.
I agree with you. We will go by the ACT.
Any specific ACT you look for when you use these devices?
No, it is the same like for any angioplasty.
Intervention. Okay.
Any intervention.
What precautions for a newcomer he should take when he does an OCT to prevent if there are any complications which are likely to happen because of use of this OCT catheter?
See, basically, it's a very safe technique. But the problem is, any new thing, probably you are taking a thing inside and bringing out. First, you should become familiar with this. And then probably it's not a very big issue at all. Probably you do 2-3 pullbacks slowly, you will pick up. And what I have had in my early stages, probably 6 years when it was in St. Jude, when we were using this reused OCT catheter in a calcified lesion. This catheter got caught there in a calcified lesion. So to remove it, I had a difficulty like that was in the beginning, but off late we don't find any complications.
There's a question from
one comment
Anand
from
again.
me. So I have one comment. Sir, you showed one case which was LED proximal lesion, then a LED mid with diagonal, and you specifically stented that diagonal, leaving that LED and
Correct.
proximal LED. It was a wonderful case. FFR showed you there was negativity, values were better. Most of us, when we saw it angiographically, I thought you are planning to do only LED diagonal bifurcation, leaving proximal. But even in such cases, sir, when you take all the catheters, balloons, and wires across that proximal lesion, and there is a chance of future development of lesion in that proximal portion of LED because of so much catheter handling in that area. When you have put wire, balloon, stent, and then IVOS catheter also 2-3 times.
See, I think that doesn't happen. So we all go by the evidence. Like to do a angioplasty stenting as of today, there are only two things. One is FFR should be positive. If you cannot do an FFR, there are certain criteria on imaging, like if the lumen is very narrow, if it is less than 2 or 1.9 on OCT, if there are features of ruptured plaque or signs of inflammation, and you take all this criteria and decide on stenting. But if FFR is negative and imaging also, there is nothing there, lumen area is more than 5.5, you will not gain anything by putting a stent there. So
future angiographically, is there any future progression of disease in the proximal area where we have so many exchanges of catheter?
No, that exact follow-up we really don't know. But this patient which I showed is almost 3 years now. I think he is doing very well. Comes for follow-up. That's all we can see that.
Right.
Thank you. There is a spate of questions. I think there's one about osteal lesions. But I think you have shown that very well, how OCT is so useful in osteal lesions, very elegantly demonstrated by you with case examples. So I won't, we will skip this question. There is a very important question. In intermediate lesions, which one you prefer, OCT or FFR?
Yeah, so today both modalities are very important in taking a decision whether to stent or not. So FFR is a time-tested thing for a long time. If FFR is negative, probably you can say that does not require any therapy. But there are certain conditions where FFR cannot be done, or you still cannot go ahead with FFR and take a decision. So for that, the utility of OCT is very much well accepted. Actually, I had all this interesting presentation next also, but lack of time, we will just tell you this. As I already told you, for example, in an acute MI, in a culprit vessel, whether to stent or not, you cannot do an FFR there. So in such cases, you go do an imaging, you look at the lumen diameter. So we have a lumen area which is going to be FFR positive. Like for example, something between 1.9 to 2.4 on an OCT. If the lumen, I'm talking about the lumen area. So if the area is between that, if you stent it, it is acceptable because it is equivalent to FFR positive lumen area. Apart from that, along with that, if you see that there is a ruptured plaque and then a lot of macrophages and thin cap atheroma in a lumen which is 1.9 or up to 1.9 to 2.4, we go ahead and stent it. And of course, there are certain conditions like if there is a left main disease and LAD is giving a collateral to RCA, FFR cannot be done there. So in such case, you do OCT or IVUS, you look at the lumen diameter and take a decision in the left main. And similarly, if a patient has severe aortic stenosis or he has severe LVH or he has severe LV dysfunction where end diastolic pressures are high, your FFR will be wrong. So in such conditions, we apply imaging, take imaging's help and then take a decision there.
So basically, in a nutshell, FFR is the physiology, and the physiology is the investigation of choice for intermediate lesions. unless FFR cannot be done in that.
Yeah, that is true.
So with there, OCT will be useful. And there's one more question. In real-time practice, how many times OCT helped you to avoid perforation in
See,
calcium?
Yeah. See, Bob, whatever learned we did is we learned from our experience. Now, we specifically when I'm treating calcified lesion, that too after rota or in a very unhealthy vessel, we search for those findings on OCT. We should, unless you are aware and search for it, you will not get it. So if you see that findings, we are less aggressive. So our incidence of perforation is very less now. But I really cannot say that how many times it has helped.
Yeah.
Definitely our complication rates are less. And in most of our live case demonstrations also, we show them on OCT that these findings are there. So better be slow, but don't be very aggressive. And probably perforation rates will come down.
In fact, I liked your choice of balloon. You showed us one case where you, after the rota, you used a cutting balloon and a scoring balloon. And I like your choice of a very short cutting balloon, lengthwise, very short, because that is very important. One is it is more effective. It will deliver all the force at the nodule or at the tightest portion. And secondly, it is safer. It won't dumbbell. That is very important. Rahul, shall we call it?
Yeah. So
A
before
day, because questions are coming, but I think it's already
it's
past
9:30, so quite a time. So
Yeah.
before I concluding the session, I have some announcement for CSI Pune. Next month we don't have our monthly meeting, but we have our annual meeting, which will be scheduled on 23rd of April, that is Saturday, and that will be between 5 p.m. to 9 p.m. We have two international speakers, Dr. McMurray for heart failure and Dr. Patrick Serious for intervention lecture. And we have 4 national faculties. So I would like to invite all of you to be present. And this last year we had 1,200 attendance. So it was quite a huge attendance we got it. And we expect that this year also. So whoever are present today, I would request you to just communicate with your physician colleagues also and cardiologists so that we have maximum people to attend that meeting. So
thank you, Rahul, for that message.
Yeah.
And before I finish, let me say I really enjoyed. I'm sure everyone enjoyed Dr. Selvamani's talk. It's a very important talk because it's something new that is coming into Pune, and it's not that commonly practiced. And I think you gave us fantastic examples,
yes,
very good insight. Thank you, Dr. Selvamani, from on behalf of Pune.
Yeah,
fine.
So
thank you very much for calling me there. Also, I also enjoyed all your questions and your discussion. And thank you very much.
So special thanks to you, Dr. Selvamani. And also Dr. Makhle, who is not attending today's session because he had some emergency, but it was very kind of him to call you on that evening when I was with him, and we could able to arrange your talk. But I have seen you personally at Ruby Hall, so we are very well versed and we know the depth of knowledge and the skills what you practice. So thank you very much. We look forward for future association again. And I conclude this session. Also like to thank MQR Pharmaceutical and also all the participants who were keen for learning this OCT masterclass. Thank you and good night.
Yeah. Good night.